Hello, this is Dr. Wendy Wood, and we're going to continue talking about wounds. We'll be talking about neuropathic ulcers. And when we refer to that, we're mostly talking about diabetic ulcers. With patients with diabetes, you need to check their sensation, and the patient should monitor and document their blood sugars. Very important. Here is a picture of a patient with a first metatarsal wound. Most of these diabetic ulcers are on the bottom of the foot, and they could be in other areas also. So neuropathic ulcers, again, also known as diabetic ulcerations. Over 24 million Americans have diabetes. These statistics are from the early 2000s. And numbers may be changing. We do know that diabetes is going to be increasing in incidence. And diabetes is responsible for over 600,000 amputations annually. 50% will have a contralateral ulcer within 18 months, and 50% will have a second amputation in 3 to 5 years. Diabetes mellitus is a disorder of carbohydrate, protein, and fat metabolism related to alternations in the body's ability to produce or use insulin. Etiology. Again, diabetes is a disorder of carbohydrate, protein, and fat metabolism. And again, related to the body's ability to produce insulin. So there's type 1 diabetes, which is about 10% of cases, typically diagnosed in children or young adults. And this results from an immune-mediated destruction of the pancreatic beta cells. Type 2% accounts for about 90% of the cases of diabetes. Tends to be diagnosed in middle age or later. Approximately 80% that are diagnosed are overweight. There is also a genetic predisposition to developing type 2 diabetes. The etiology of diabetes related to tissue damage. Hyperglycemia causes changes in red blood cells, platelets, and capillaries, and it alters the blood flow. It increases microvascular pressure. So normal fasting range of sugar is between 65 and 99 milligrams per deciliter, or I should say fasting range of glucose. Glycosylated protein causes tissue damage also. 2 to 3 month indicator of glucose control. It's the AC1 test, which is very important. Normal is between 4 and 5.6%. 5.6 to 6.4% is at risk for diabetes. 6.5% or higher is diabetic. An accumulation of sorbitol due to the breakdown of glucose results in tissue breakdown or tissue destruction. Some of the risk factors contributing to delayed healing in terms of diabetes and wounds are vascular disease, neuropathy, mechanical stress, abnormal foot function and inadequate footwear, impaired healing and immune response. Poor vision, characteristics of these ulcers, disease characteristics, and inadequate care and education. Neuropathy, the most common complication of diabetes, and the causes of this are neural ischemia and segmental demyelination. It tends to be symmetrical and distal. It can also affect sensory, motor, and autonomic systems. So think of the stocking glove, tends to be distal, so kind of in the hands and in the ankles and feet. Some of the risk factors continued with sensory neuropathy. 50% of patients are unaware that they have lost protective sensation. A lack of protective sensation can equal a lack of early detection to irritation or trauma, paresthesias. So how do we describe this? If the patient's unable to perceive 10 grams of pressure, they're at risk for ulceration. We're going to talk about the monofilaments soon. With autonomic neuropathy, you typically see dry, cracked skin due to decreased ability to sweat, increased callus formation. Arteriovenous shunting leads to decreased perfusion, and uncontrolled vasodilation can lead to osteopenia. With motor neuropathy, you tend to see intrinsic muscle weakness and atrophy, decreased foot stability, and this can lead to deformities, and increased pressure and shear forces to the foot. So here is a picture of a Charcot foot. This would relate to Charcot-Marie-Tooth syndrome. So you can see the huge changes between the healthy foot and the collapsed Charcot foot. Abnormal foot function and inadequate footwear. With inadequate footwear, we see impaired range of motion, especially with the great toe extension and dorsiflexion, subtalar joints, and increased vertical pressure and horizontal shear. Some of the foot deformities, plantar fracture, contracture, varus or valgus, Charcot foot, and if there's a prior ulcer or amputation, poor footwear is not going to protect the foot. It's going to decrease pressure, shear, or accommodate deformities. Impaired healing in the immune system. There's a decreased ability to build new tissue and fight infection, a decreased ability to fight infection off, and increased frequency of osteomyelitis, soft tissue infections, and candida. So this can impair all three phases of wound healing. Poor vision. Diabetes is the leading cause of retinopathy, glaucoma, and cataracts. There's an increased risk of trauma, and it decreases the ability to perform adequate foot care because the person's not able to feel pressure in the foot, and then if the vision is impacted too, they can't see any problems. Ulcer characteristics, usually with neuropathic ulcers, they're larger and deeper and they take longer to heal. The wound presents for longer time. So some of the tests and measures that are used, circulation tests like the Doppler, sensory integrity. All patients with diabetes should be tested with the Symes-Weinstein monofilaments. So what you want to do is occlude the patient's vision. So you should be testing them, have them close their eyes basically. The 5.07 monofilament equates to 10 grams of pressure that we talked about area. You want to avoid the calloused areas and test each location randomly 3 times. And the great thing about these monofilaments is if you look at them, the monofilament, it usually has a guide to where you should test. So you can also test pulses in the distal extremities. Do the Doppler ultrasound and the ankle brachial index and look for capillary refill time. So here's a Symes-Weinstein monofilament. There are different brands and some of them are smaller than this. These are the locations to test and most of the monofilaments will show you that. Here's a patient with a neuropathic ulcer prior to debridement. You see a ring of callus around the wound at the plantar aspect here. And this is actually caused by a Charcot deformity. Okay, Wagner classification is used for neuropathic ulcers. Grade 0 is no open lesions, but they may have a callus. Grade 1 is a superficial ulcer. 2, deep ulcer to tendon, capsule, and bone. 3 is ulcer with an abscess, osteomyelitis, or joint sepsis. And 4, localized gangrene. And 5, gangrene of the entire foot. And remember, this classification only applies to the neuropathic foot, the Wagner classification. And this is the same wound after debridement. That would be classified as Wagner grade 1. Some of the prognosis for healing, the superficial ones of Wagner grade 1 or 2, there's poor healing if the size is large. If it's been present for less than 2 months, let's kind of go over that again. There's good healing in the smaller ulcers, grades 1 or 2, if they're present less than 2 months, and also ulcers decreasing in size within 4 weeks of treatment. There tends to be poor healing with larger ulcers. The risk of amputation is 154 times greater with infected ulcers. If there's a 20 to 50% decrease in size not noted in the first month of treatment, chances are the healing will continue to be poor. So some of the instruction that's important, talking to the patient about the disease process, management of diabetes mellitus, the role of exercise and safety guidelines, risk factor reduction, daily foot checks, use a mirror, and foot care guidelines, as well as proper footwear. Some patients need custom footwear. And then toenail care is very important. Some of the physical therapy interventions, you have to realize patients may not show signs of infection due to decreased inflammatory response or PVD, peripheral vascular disease. So you might need to request culture and sensitivity for wounds that fail to respond to interventions. And osteomyelitis needs to be treated surgically. Patients need to monitor their blood sugar. Hyperglycemia is common with infections and uncontrolled diabetes, but hypoglycemia may occur also. Keys to local wound care: you need to offload the pressure. You need to pair the callus. Use petroleum-based moisturizer daily. Use toe spacers if enclosing toes in bandage. Other adjunct therapies: negative pressure wound therapy, ultrasound, electrical stim, and growth factors. These are very expensive though. Total contact casting is sometimes done. A modified short leg cast used for Wagner's greater 1 or 2. And these contact casts assist with wound healing, so the cast is molded to the foot and leg, dispersing the weight-bearing forces over a larger area. It also helps control the edema, and the immobilization of the foot protects from trauma, and it assists with the patient adherence. Contraindications: osteomyelitis, gangrene, fluctuating edema, active infection, or ABI, which is the ankle brachial index of less than 0.45. So this is a picture of a total contact cast being formed. Some of the options for footwear are felt or foam inserts, padded ankle orthosis, or walking shoes. This is to help provide safe ambulation and pressure reduction. You can use when a total contact cast is not an option. The shoes should be about 1/2 inch longer than the longest toe. The shoe last should match the foot shape, and there should be extra depth toe box and the heel height of less than 1 inch. Medicare and most insurance pays for diabetic shoes, and 3 insoles per year. These are some pictures of footwear. Here's a custom boot. Of course, this person has a hip fracture, which complicated things even more. Okay, this is it for neuropathic ulcers, and I'll begin talking about vascular ulcers in the next segment. Thank you.